So I don't know whether any of you remember your bronchoscopies. Because of the drugs we give, most patients don't see this or don't remember this issue, but the only way of diagnosing rejection is to pass this tube into the lungs, and we use biopsy forceps under screening. Here they are. They're called alligator forceps for obvious reasons. Those look like chomping. So I always tell my surgical colleagues that you spend sort of 6 hours putting these lungs in, and I spend the rest of my life taking out bits of it to look under the microscope to tell us what's going on. We get very small, 2 millimeter bits. In case you're all worried, I've had 5 bronchoscopies this year. Half my lung will have gone. No, there's a lot more tissue there than you need. And of course, we use those. Much as Simon and Anne are doing a huge amount of research, both clinical and basic science, to try and understand the mechanism of disease. Because of the complications following lung transplantation, we are taking tissue and, with your consent, as you know, plating out, culturing the cells, and looking at, in models, trying to understand what it is that causes rejection, both acute and chronic, following transplantation, and ways of improving matters. So if you have a lung transplant, what sort of drugs are you going to be taking, and what are the issues with those drugs? Well, this is quite a complex issue. And we talked a little bit about this, and the slide's quite complex, but I'll talk you through it. First of all, after lung transplantation, the majority of patients are taking prednisolone, I would say, and for this slide, all patients were taking prednisolone. Rarely, if patients have had no rejection ever, we are prepared after around about 2 years to take patients off their steroid. So this slide indicates each of the bars under cyclosporin, tacrolimus, rapamycin. You'll see, and these aren't just LAM patients. Rapamycin is now used, or was introduced as an anti-rejection therapy. Mycophenolate and azathioprine, 1-year follow-ups, and these are the bars from 2002 down to 2007. So you can see worldwide there's a sort of tendency to use less cyclosporin and much more tacrolimus. And in Newcastle, we still use cyclosporin first. Are we crazy? I think not. The evidence base that one is better than the other is not really there. But if patients are getting rejection episodes on cyclosporin, we often switch to tacrolimus. And there may be other indications. Hirsutis or hairiness is a feature of cyclosporin. If that's a problem with young ladies, and it always is a problem with young ladies, we would switch to tacrolimus. And I think that is one of the reasons why tacrolimus, the side effect profile may be slightly better, but in terms of immunosuppression and outcomes. So it's interesting to see that the drug that was used or is being trialed to treat primarily pre-transplant LAM, there is a use of it, and in the 1 year, obviously later on down the 5-year program, even more of it being used, though less than 20% of patients. In truth, although this is an anti-proliferative drug, and proliferative or growth of cells and scarring is a feature of chronic graft rejection, and one might argue that rapamycin would be good at treating that. It's not been as good as we would have hoped. It is a drug with side effects, as you know, and the reality is it still hasn't impacted hugely on outcomes post-transplantation. But it is reassuring to know that if the trials of rapamycin show that in treating in general LAM is very good, then even post-lung transplantation we can use a drug quite safely in the post-transplant period that may help control other factors of the disease. And as I've already said, in case reports, we know that's true. So in the Newcastle, if you come there for your transplant, you tend to start with cyclosporin. You'd switch to tacrolimus with side effects or rejection. We use azathioprine, MMF. These are drugs that may affect the bone marrow and reduce white count and blood count. cyclosporine and tacrolimus, very much what have delivered success in organ transplantation, but do lead to high blood pressure and kidney problems. And in general now, we would use in a LAM patient sirolimus if there was LAM progression, or if there was any evidence of early loss of kidney function, then one can introduce sirolimus or rapamycin to reduce the dose of tacrolimus or cyclosporine to improve kidney function. Now, one of the problems which limit outcomes after a lung transplant, the problems are increased risk of infection because of the immunosuppression, acute rejection, chronic rejection, high blood pressure, kidney damage, and because of the infection, viral problems. But some patients get a lot of warts because of their viral etiology, and there's this relatively rare condition, post-transplant lymphoproliferative disease. This is a virus-driven, it's the Epstein-Barr virus or the a glandular fever virus, which can stimulate lymphatic cells to grow. The main problem that we face is chronic graft dysfunction. If this is a normal airway deep within the lung, these are the sponge-like alveoli, this is a bronchiole. What happens in chronic graft dysfunction is here's that same airway, but instead of it being nice and open to conduct air, it's completely blocked, or in this instance it is completely blocked by fibroproliferative scar tissue, and it leads to the presence of airflow obstruction. And so patients can develop, much as they do with progressive LAM. This isn't LAM back into the lung, but this is a rejection process in the transplanted lung that scars up the airways. But there is some good news on the front. Much as we've used, there's a trial of doxycycline, an antibiotic for LAM, we're now recognizing that antibiotics have other properties, not just managing infections. And there is now some data that an antibiotic called azithromycin might come to the rescue. We did a study looking at lung function. These are the patients who developed chronic graft dysfunction. They were given azithromycin, and these are the results 3 years down the line. 7 patients still had improved lung function from when we started the azithromycin. 5 patients had stable disease, and of the 17 that were still alive 3 years after their chronic rejection, only 5 had shown continued decline. And we've now taken this data forward and are doing a placebo-controlled study to be absolutely sure we've got good evidence on which patients will benefit most from that. But I think you can see that from that pilot data, azithromycin appears to be improving or stabilizing lung function in around 75%. And more importantly, whereas in the past, survival after developing that complication, only around 50% of patients would still be well 3 years and follow-up. 85% of our population of patients were well. So there is, I think, room to optimism. We're slowly carrying to increase and improve the outcomes. Now, I'll just, for 5 minutes, this is an important area, and one I think which is very much at the front of everybody's mind in terms of the role of transplantation in treating advanced disease. How serious is the shortage of donor lungs, and what is being done about it? Well, I've already indicated there's a huge amount of work going on to target an increase in organ donors by 50%. But there are other ways that the transplant community are using. Ethically, although the brainstem death is clearly or donors who've got brainstem death are those where the majority of organs. There are patients who have cardiac arrests in hospital or are brought to hospital with their heart not functioning. And there are now ethical permission to use patients with no chance of recovery who've got non-heart beating donors. The lung in particular is actually survives pretty well, even though there isn't an intact circulation.